So, good evening, everyone. I'll be talking about CSR and the pachychoroid spectrum disorders. Uh, how do I? So, pachychoroid, the term was coined way back in 2013 or 14 by Bailey Freund and his colleagues. It defines as a condition. It is defined as a condition which has a thick choroid with RPE disturbances with or without subretinal fluid, and it is not one disease per se. It's a continuum of multiple diseases which can present differentially. The evolution now encompasses focally or diffusely thickened hallus layer with a secondary compression of the overlying choriocapillaries. The first component of a pachychoroid spectrum includes the pachychoroid pigment epitheliopathy. Here, if you look at it, you can see the photograph below, and the points which I've written here are just the descriptive markers which you can see in the OCT picture. I would like everybody to just focus on the OCT presentation. The yellow arrows which you see here are focal RPE epithelial abnormalities like focal or diffuse increase in the defects in the RPE. Along with that, underlying the RPE, you can see dilated choroidal vessels which are highlighted in the blue arrows, and typically here there is no subretinal fluid. This, if you see, this is how the fundus would look. To the untrained eye, probably this would look like a normal fundus, but if you look very carefully to the nasal part of this part of the fundus, you can see some mottling and RPE pigmentation changes. And the important investigative modality here to utilize is FAF, fundus autofluorescence. So when you do that, it very beautifully highlights the differential changes which are there at the level of the RPE. Another OCT feature which is found in the same set of disease, in addition to the pachy vessels, RPE changes and the other things, is an irregularity in the RPE which is highlighted as the yellow line here, and an elevation of the above overlying lines in the layers in the internal interdigitation zone. There may be also a presence of PED, serous PED, along with the dilated choroidal vessels. And mind you, here again, we do not see any serous macular detachment. Fundus autofluorescence and IC78 are investigative modalities of choice which help to delineate the disease and differentiate it from the other sinister variants of the same. Another disease in this spectrum happens to be the pachychoroid neovasculopathy. Now, as the name neovasculopathy suggests, it is actually a set of new vessels which develop from the choroidal vasculature and come to lie below the RPE. On the fundus, you can very characteristically see subretinal hemorrhage, RPE mottling, pigmentation changes, and the most striking feature which will differentiate it from a wet ARMD would be the absence of drusen. And when you do an OCT fundus autofluorescence, the presentation is no different from the one which we saw previously, and it is very difficult to identify it on an autofluorescence unless and until there is a large amount of hemorrhage which you see here. If the hemorrhage is very dense, you can see a masked large area of hypoautofluorescence. Doing an ICG also helps highlighting choroidal hyperpermeability in these areas. The whitish lesions which you see here are hyperfluorescences due to the choroidal hyperpermeability. The pachychoroid neovascular features can have lesions below the RPE. That's a type 1 lesion. Subretinal fluid will be there here, which indicates the exudation. A shallow irregular PED or a DLS, as you call it, double layer sign, and infrequently there may be some element of cystoid macular edema. The other treatment modalities here, as we have seen already, ICG and autofluorescence are important, and one more important modality which happens to be non-invasive and gives a very good utility in following up these patients is OCTA, which can actually delineate the lesions very well and can be followed up based on that. This is how the lesion will appear. All modalities put together. This is the fundus picture. Here you actually cannot make out any fundus or any hemorrhage here. Other than the RPE mottling, you cannot make any difference whatsoever. Autofluorescence will actually only delineate the area of hyperautofluorescence surrounding an area of hypoautofluorescence. ICG will show an area of hyperfluorescence in the later phases, and OCT will show some element of serous macular detachment, irregularity of the RP, and some fluid below it with a thickened choroid. The third variant is a PCV. Now, PCV, I have not deliberately put any photographs because it's a separate topic in itself. It is just to iterate that it forms the same part of the continuum. We've had some patients which started off in one eye with CSR chronicity over a period of set of years, and 15 years down the line, the same patient landed up with a focus of PCV in the same eye after a period of 15 years. So these form the part of the same continuum. Another characteristic feature which is seen in this, the fourth element which is seen here, is a peripapillary pachychoroid syndrome. It's called the PPS. It's typically has been defined as a present occurrence which is seen in the eyes of the contralateral eyes of patients with CSCR, and generally it is seen nasal to the macula with choroidal thickening near the optic disc. The features usually would include chronic choroidal venous hyperpermeability, pachyvessels, pigment epitheliopathy, and serous PD. More or less the symptoms are similar, but to differentiate between the two is just identifying the morphology and looking at the various kind of a pattern recognition. You see it 2 times, 3 times, the 4th time your brain will automatically feed you the diagnosis. And the last part in this is the focal choroidal excavation. This is a very common finding which occasionally all of us would have seen in OCT findings, and we usually don't register this we don't register it very aptly. But while looking at it in the literature, then we get to know that yes, this is what is called a focal choroidal excavation. Now, it has a twofold implication. It can be a sequelae of a disease, and it can be the initial insult with which the disease develops. So it can be the cause as well as the effect. And this is of two types. It can be a confirming type and a non-confirming type. In the confirming type, the overlying retinal vessels actually course the entire curvature of the focal choroidal excavation. And in the non-confirming type, as you see here, the cavity dips down below and the layers are above in the upper part. There's a gap in between. So the pathogenesis is mainly said to be due to the venous overload, choroidal congestion, vascular remodeling, and RPE dysfunction, all of which lead to these different presentations. The importance is these differential diagnoses are the things which happen to differentiate these from the other sinister variant, that is the age-related macular degeneration, and the prognosis and the need for treatment. Which lesions need to be treated, which lesions need to be observed is important, and that is why differentiation amongst the different types is important. Thank you for your kind attention.